So we've gotten our history, we've done our external and internal exam. So what are the steps that we actually follow as technicians for our dental prophylaxis? And prophylaxis is just another term for our dentistry or dental cleaning. And you do need to know these because we are going to follow these steps when you clean your section of the mouth. So write them down, have them with you. I want you to know how to proceed here. So we're going to start with that visual examination, extraoral, intraoral, and then we're going to go on to probe our pocket depth. And we're going to use our dental probe and explore that cemento enamel junction where the gingiva attaches to the enamel of the tooth, because we've said in healthy, normal teeth, we shouldn't have much of a pocket there. The structure, the cementum, and periodontal ligament hold that tooth in pretty tight. So if there's any kind of a pocket there, we may have some disease process going on. We can explore the topography of our tooth using our dental explorer, looking for cracks, fractures, and so forth. And then we will take radiographs. And at present, this is not something we're able to do in class. We don't have the ability to do that, but most practices will. And this is something that is pretty important to make sure that we're not missing any kind of problems. So once we've identified what's going on, if there's any teeth that need to be extracted, we want to go ahead and apply some kind of a antibacterial rinse to the mouth. So we're going to use a dilute chlorhexidine solution. It's usually about 10 times more dilute than what we would use for something like our surgical prep, but they also make specialized dental solutions for this purpose. But this is something we don't want to skip, because in the process of doing our cleaning, we're going to spread a lot of bacteria that was under the gum line around the patient's mouth, around our work area. Potentially we're going to expose ourselves to it as well. So really helps the patient if we do this before we do anything that's really invasive. Next, we're going to go on to our hand scaling, and like we practiced, this is going to be getting off kind of the bigger chunks of calculus, getting whatever we can out debris wise. Of course, we always want to be careful not to damage the teeth themselves. And then our ultrasonic scaling. And our ultrasonic scaling, as I mentioned before, we really are able to get under the gum line and get to those things that maybe we can't see or won't be able to remove with hand scaling alone. Finally, we will do our polishing. We're going to sand down all those little grooves that we made with our scaling and hopefully prevent the biofilm from depositing in that area as quickly. And then the last step is application of fluoride, just like they did for us at the dentist when we were kids. I don't know if they do this in adults as much, but definitely for children they still do. We're going to apply a layer of fluoride that helps strengthen those teeth over time. So I said the periodontal pocket is what we're going to evaluate after we've done our visual examination. And another way that they describe this periodontal pocket is by saying that the gingiva form a moat around the tooth called the gingival sulcus. And this is where the crown attaches to the gingiva. And so if we take our probe and put it under the gingiva, right at that cemento enamel junction, we should only be able to advance that probe 1 to 3 millimeters in a dog and up to 1 millimeter in a cat. And if we're able to fit that probe any further down than that, we're not going to force it, but if it slides any further down than that, then we may have some damage to that periodontum that needs to be evaluated either radiographically or through some other means to make sure that that tooth is still healthy and can be retained in that mouth. So 1 to 3 for a dog, up to 1 millimeter for a cat. So this is an example of using our dental probe, and different types of probes have different types of markings on them, but they're generally going to be in increments of 1 millimeter. And we're just going to slide it up between the tooth and the gum line and see how far it'll advance. So this is a patient that actually has, looks like some significant gingival recession. So I think in this case they're also measuring where the gum line should be compared to where it actually falls on the tooth. So it is another way that we can just have a ruler in there to measure structures and then document those. So because the dental probe goes under the gum line, it does have a blunt tip. And a couple different styles here. You don't need to memorize these for the test. I don't think that they're on the VTT in terms of specific dental probes, but we do want to be aware that there's different measurements out there. So wherever you're working, make sure you understand the type of probe that you're using. So if you have something like a marquee probe, you may have millimeter markings in increments of 3s, whereas your Williams probe, it's going to be 1, 2, 3, and then a marking at the 5 millimeter, 7, 8, 9, 10, and I believe that's what we currently have in our dental kit. Then you've got the UNC probe where the millimeter markings are in increments of 1. So whichever one you're using, just make sure you know how to count those increments so you can document correctly what's going on with your patient. How do we use the dental probe? We want to slide it down into the gingival pocket there and walk it around the circumference of the tooth. So we need to make sure that we walk 360 degrees around the tooth, but what we don't want to do is just kind of spin it around the tooth and enlarge that pocket or damage the structures there. So short up and down strokes every few millimeters, and then we'll document what we see. So I may document that most of the mouth had a gingival pocket of 1 to 2 millimeters, except my canine tooth on the upper left, which had a pocket of 4 millimeters or so. The Dental Explorer is a thin wire with a sharp tip, so we're not going to put this below the gum line. It's used to explore the topography of the tooth. So you may have had this experience with your dentist where they kind of tap it around the tooth, particularly the occlusal surface or the surface where you bite down, and look for evidence that the enamel is damaged. Because if the enamel is damaged and the underlying dentin is exposed, instead of having kind of a hard surface, you're going to feel more of a sticky or soft surface with your Explorer. So it's simply like an extension of our hand to be able to feel what the surface of the tooth has intact or missing. A couple different types here are Orban, Pigtail, ODU, and Shepherd's Hook. You don't need to know the different types, but you should be able to pick up a tool and say, this is a thin wire with a sharp point, much less sturdy than our scalers. This is going to be a Dental Explorer. I think our packs currently have the So we've done our dental exam, we've done our dental radiographs, and now comes the job of actually removing what we have there under the gum line as well as on the tooth surface itself. And this is yet another time we use this term debridement. So removing the plaque, hopefully getting rid of those endotoxins and bacteria, as well as slowing or halting whatever disease process is going on. I can only imagine how much better they feel once we've gotten all that stuff out of there, as pictured in that earlier slide with that dog who has that crazy pus along the gum line and buildup of calculus. He's got to feel better going home after we've done this, right? So we're going to apply our dental rinse. Chlorhexidine solution is one of the more common, helps to kill the anaerobic bacteria in the mouth, and remember we said it has a long period of residual activity, so it works for a couple of days, which can be helpful for our patients as well. Sometimes this will be combined with something like a zinc ascorbate solution, which works by oxidizing the bacteria, and these have the advantages of also helping to stimulate collagen formation, rebuild some of that tissue. Probably has a very minor effect, but maybe it helps, and when the two of these are combined, that's nice for our patients as well. Our dental scalers are used for removal of the calculus and plaque on the teeth. They do have pointy tips because they're made for supragingival scaling only. So we said things with a blunt tip go below the gum line, things with a sharp tip stay above. So these definitely supragingival stay above the gum line, and they have a cutting edge to them. So what we want to do is identify that cutting edge, and they come in different shapes. So if we're working in different parts of the mouth, different teeth, we can figure out which tool is going to conform or wrap around the tooth best. And we're going to take that cutting edge and pull it up against the enamel away from the gum line to be able to remove as much of the plaque and debris as we can. Our ultrasonic scalers will be what we do after our hand scaling, and in some practices you may not do much hand scaling, or you may just do it very briefly to remove very large deposits. The ultrasonic scaler does an excellent job of scaling, so we don't always need to use hand tools. We will in class, since it's an essential skill, and because I want you to have some feel for that. But the ultrasonic scaler does an excellent job, works through cavitation. So ultrasonic is sound waves, and then we've got water flowing over the tip, and the sound waves explode, those little bubbles kind of vibrate the water there, and that breaks up the deposits on the surface of the tooth. The ultrasonic scaler also has a blunt tip, so we can work it below the gum line and reach some of those structures and areas that we can't do with our hand tools, or that would, cause a lot of damage if we put something sharp under the gum line. So the ultrasonic scaler is usually far more efficient than our hand tools and less work on our part. The downside of the ultrasonic scaler is that if we use it improperly, we can damage the tooth. So we don't want to apply any pressure when using the ultrasonic scaler. We don't want that vibration right up against the tooth. That vibration heats the tip as well, since it's vibration going through metal. And if we then contact that with the enamel of the tooth, we may damage the structure we're trying to help. So we avoid that damage by never pointing it at a 90-degree angle to the tooth. We're going to use the side of the scaler and not apply any pressure. We're always going to keep the tip moving, so no more than 5 to 10 seconds per tooth, and we're never just going to concentrate on one area. If we can't get the deposit off, we can always come back to it later. We can, on some machines, adjust the power setting, so adjust the vibration, and low power may be appropriate for most situations. Certainly we want to use the lowest power we can to do the job that we need, but higher power may be required for patients that have large deposits. And we should never, ever, ever be using our ultrasonic without the water. So if your water stops running, or if you have a machine for which the water doesn't flow well over the tip, we need to address that, because the water, we get that cavitation action from the bubbles, and it also keeps the tip cool enough that it's safe for our patients. The ultrasonic scaler causes cavitation of those water bubbles. So the water bubbles vibrate and then explode, which not only helps us remove the tartar more efficiently, but also destroys some of that bacteria. So that is terrific. Another benefit over our hand scaling. But we do have to think about the fact that we are just spraying this water with bacteria and debris everywhere. So we want to protect ourselves by wearing goggles and a mask. Absolutely, this should not be something that's optional. You need to have some kind of eye protection. A lot of practices will have you wear a mask that has a plastic visor. That's perfectly fine, but do think about your own safety here. And, if you're going to be there that day doing other surgeries or seeing other patients, consider wearing a paper or another type of gown over your clothing as well, because that's just kind of gross, going and having your lunch covered with the bacteria from that patient's mouth. We also need to consider protecting patients from their own bacteria, making sure their eyes are really well lubricated. Ideally, we're doing that every hour. For patients that are anesthetized, period, we want to put some kind of lubricant in relatively frequently, but for dental patients, we need to watch that even more closely. They should have a good layer of that artificial tears ointment. And we want to have that cuffed endotracheal tube so that none of this bacteria or debris makes its way into their airways. We don't want to get aspiration pneumonia. I try when possible to position the patient so that water is not flowing down into the GI tract or into the trachea. So I'm trying to position the patient forward with good drainage. I may also on these patients wait a little bit longer to uncuff that endotracheal tube when they're recovering to make sure that none of that debris makes its way down there, that they're alert enough to protect their own airways. I've heard some technicians and some doctors talk about leaving the endotracheal tube just slightly inflated with air when we're removing them after dental procedures. The idea is if it's slightly inflated, if there's any debris in the trachea above the cuff, so it hasn't made its way down into the lungs yet, but it will, then if you have it slightly inflated, you're kind of sweeping that debris up with you when you pull the tube. I think that this is probably not harmful, but it's probably not terribly helpful or necessary either. So you can do what your practice is comfortable with. I doubt it makes a difference either way. So ultrasonic scalers or power scalers, we get that destruction to the bacteria from the cavitation of the bubbles. We get lavage, so we're constantly washing away since that water is streaming. We get less tissue damage, as well as less damage to the tooth with power scalers than with hand scalers. Even when we're using our hand scalers correctly, we do more damage with them than with our ultrasonic. Hopefully this all results in less time that the patient will remain anesthetized, and ultrasonic scalers usually require less effort on our part, which is important. The ergonomics of dentistry is important because you may spend 2 hours on the procedure and in a position hunched over the table in the patient's mouth, and you may be doing several of those a week or sometimes several a day, and that does add up for us. So you want to think about the ergonomics. Can I sit down? Can I position the patient so I'm not leaning over the table quite so much? That is absolutely important for dental procedures, so do keep that in mind. Curettes are our subgingival scalers, so these have blunt rather than sharp tips, and they're made to reach underneath the gum line and debride, pull up that debris, and in turn release that bacteria, get it out of there. So they do still have fairly sharp tips, but they're more rounded, more blunt than our other scalers to help avoid trauma to both the gingiva as well as the periodontal ligament that attaches the tooth to the other structures. Whether we're using our hand scalers or our curettes for subgingival scaling, we do want to make sure that the working end of the instrument remains in contact with the tooth surface to avoid gingival trauma. This is particularly important for our curettes, but we need to choose one that conforms to the surface of the tooth that we're working on. So kind of wraps around it so that we don't get the blunt tip poking kind of outward into the tissue structures there. Should be lined up against the tooth, that lower third of the working end. So this diagram shows how we would use our subgingival curettes. We're going to go ahead and work them underneath into that periodontal pocket and open them up into a 60 to 80 degree angle and then pull coronally, it says, so towards the crown of the tooth to dislodge any tartar. We may have to remove some of that cementum as well, but we want to try to get out as much of the debris as possible. So we are going to have to open up that attachment a little bit to pull it out. This is a good example of why power scaling is superior. To really get under the gum line with our subgingival scalers, we do some damage but this is better than the alternative of leaving that debris and bacteria underneath the surface where it's damaging the alveolar bone as well as the other attachments there. So once we've got it underneath the tooth, we open it up to that 60 to 80 degree angle, pull it up towards the crown of the tooth. We do want to make sure that we never use an angle that's greater than 60 degrees, so we're not damaging the soft tissue, lacerating the gingiva there. Polishing we can do by hand if we have something just like a toothbrush and our Prophy paste, which is that gritty paste, kind of sandy consistency. We can apply it to the teeth and we can brush them, and that's going to get some of the grooves that we made from our scaling out of there. But more commonly we're going to do this with our power polisher, and that has a little Prophy cup. That's the white rubber cup that fits on the end of the polisher, and it spins. We fill it with Prophy paste, that sandy paste, and then it's kind of like having a power sander. We're going to reduce the little grooves that we've made, and hopefully the biofilm won't stick. Biofilm adherence is decreased. This stuff kind of goes everywhere, so we still want to use our general rules of having eye protection, ideally a gown for ourselves as well, and having lubricant in the animal's eyes. We're going to use relatively low speeds for this. We don't want to damage the enamel. Really what we want to do is just go over every surface of the tooth once or twice, generally no more than 3 seconds per tooth, to decrease the possibility that we're actually going to damage particularly thermally damage the underlying structures there. We don't want to polish or sand off the enamel, just smooth it out. After we're done, we can rinse the mouth. Our machine, we've got that nice water and air rinser that works really well. If you don't have that, you can fill something like those little alcohol bottles with water so that you can rinse well. You can use gauze to dry if you need to. And then you can reassess for smoothness. I don't know that there's really a good way to do this, but I do want to make sure that I've gone over the backs, 360 degrees around the teeth, as well as in that subgingival region. So the Prophy cups have a little flare. I want to make sure that I get those below the gum line where I'm worried most about tartar deposition, right? Other products that we may use for treating or preventing periodontal disease, doxycycline gel is one of my favorites. It's a polymer, so like a plastic, that is impregnated with doxycycline. Doxycycline is an antibacterial, and we can use this below the gum line, or if we've extracted a tooth and we need to fill that region, fill that socket, we can inject this polymer. And it comes in 2 separate syringes. We attach them and then we mix the gel together. And once it comes in contact with moisture, like blood or saliva in the mouth, it hardens and takes on that plastic consistency. So it's neat because it'll stay in place for a long time. And we can also, as I said, kind of inject it under the gum line, which is that photo in the lower right, and get it into just little crevices that would otherwise maybe play host to bacteria while the body heals the gingival moat around the tooth. The antibiotic can do its job and keep that tissue healthy, free of bacteria. We've also got things like Consil, which is what they call an osteoconductive material. And if we have a lot of alveolar bone loss, or maybe we've had to take bone out when we've extracted a tooth, we can put this material in, that's going to be on your top right there, as a scaffold for new bone growth. So it provides temporary structure and a place for that new bone to hold on to while it grows in place. And we won't necessarily be able to replace all that bone, but the body is usually able to replace some of the bone loss if we've treated the underlying disease. We've already talked about chlorhexidine, and some clients will want to take something home to help freshen their pet's breath. They do make these chlorhexidine solutions that are made for that purpose, and oftentimes they're kind of minty as well. The client may use that every day or every couple of days, so you may see those over the counter in your clinic or at PetSmart. And finally, we have the Porphyromonas vaccine. And the Porphyromonas vaccine is not in widespread use. Last I knew, the only clinics that were carrying it were the Banfield chain of hospitals. And this is a vaccination that was intended to serve as a preventative for dental disease. So in theory, it prevents some of the anaerobic infections from taking hold. Unfortunately, it doesn't seem to be very effective. It doesn't seem to do that job very well. And even if it does prevent some of the infection from taking place, it doesn't prevent the calculus deposits or the changes in alveolar bone or other bacteria from growing in that area. So there's been no real evidence that this is effective in the long term against dental disease or the development of periodontal disease. So this is not something that most clinics recommend to their clients at this point. There just isn't enough evidence to support its use. If we find something like a lack of attachment in a tooth to the underlying periodontium, so maybe the bacteria has eaten away, or something like a resorptive lesion, which we'll talk about shortly here, where part of the tooth has essentially disintegrated. If we have something like a broken tooth, we may decide to extract that tooth. So ideally, we start this process by performing some sort of a regional block. So we're going to administer bupivacaine or lidocaine to a nerve that anesthetizes the area that we'll be working on. And there's a variety of different dental blocks depending on which tooth we'll be working on. So I included a video in the playlist. It's a little bit on the long side. It's about 10 minutes, but goes through all the different dental blocks, and these are something that technicians can definitely do, and more they're becoming the standard of care because it's cheap, easy to do. They're MAC sparing agents for our patients. So instead of having to turn that patient's anesthesia up while I'm really working on pulling that tooth out, we may be able to avoid additional anesthesia, which is helpful during a long procedure. And then when the patient wakes up, they're less likely to be in pain, more likely to start eating again. So these are very helpful for us, easy to do. A lot of practices are doing them, and if they're not, you can definitely be an advocate for your patient and say, hey, why don't we try this? I read about it, I saw a video on it, it's easy to perform, it's cheap, not difficult to do, so do take a look at that if you get a chance. There are two different extraction techniques that we use. The first is the closed extraction technique, and this is appropriate for single-rooted teeth. And with this technique, we're going to use our dental elevators. I'll show you those in class, but those are the ones that just kind of have a long rod at the end of them, sometimes with a flare at the tip, so that we can work them up and around the periodontal ligament into that cementum around the tooth and disrupt the attachment of the tooth to the structures. And once we've done that all the way around the tooth, we're going to pull the tooth out with our extraction forceps. These are also called rongeurs. So closed extraction, we're not really exposing any underlying bone. We're just going to work our elevator up and around the tooth and then extract the tooth by pulling it out. So this would seem to be relatively straightforward, but if you have multi-rooted teeth or teeth where there is any kind of abnormality or a tooth in a bigger patient, doing this may not be as simple as it sounds. I've seen people literally take that elevator sort of like a chisel and apply a hammer to the end, trying to work it up and under, break those periodontal ligaments, and as you can imagine, having a hammer and a chisel taken to your head results in a lot of discomfort for our patients. Not an ideal situation. So when this works well, it's perfectly appropriate, but when you have teeth that are harder to get out, we may want to go with our surgical extraction technique. Surgical extractions are required for any kind of multi-rooted tooth, and we may also use this for single-rooted teeth if they're large or in our bigger patients. It's relatively easy to get teeth out when there's a lot of damage to the underlying alveolar bone, but if you have something like a young, healthy patient that has maybe chipped a tooth that needs to be removed, that tooth may still be well attached by the periodontal ligament, and using a closed extraction technique may not be a good choice for them simply because of the amount of blunt trauma we have to do to the structures to get it out. So surgical extractions come in handy in all of those situations. And I've included a good video with this. What we're going to do is create a gingival flap. So we do that by incising with our scalpel blade on either side of the tooth where the root would be. We're going to peel that gingiva away and expose the root. And at that point we can use our drill to remove some of that bone, holding the tooth in. And once we see the root well, we may not remove all that bone, but at least some parts of it so that we can elevate the tooth, use our elevators to get up and around the tooth. Sometimes we also have to section the tooth, so we may take a multi-rooted tooth and cut it into 3 pieces if there's 3 roots, so we can use our elevators on each root and then use our rongers to pull the tooth out. So this may seem like more steps, and in the video it gets a little bit bloody, but he manages to get the whole tooth out in about 10 minutes versus a closed technique where we may be working on that for significantly longer. So surgical extractions may seem longer, may seem like more steps, but are usually less physical trauma to the patient and usually easier for us as practitioners once we've gotten some practice at doing this. Once we've got the tooth out, we can suture that gingiva over the opening in most cases. So we've said exodontics, extraction, endodontics, root canal, gone through our closed extraction techniques for single-rooted teeth, surgical extractions for multi-rooted, and when do we remove teeth? I talked about some of the situations: tooth fracture, resorption, and periodontal disease. Anytime that tooth is no longer attached well to the underlying structures, it's causing more of a problem than it is helping the patient. It's causing them pain, and it's not doing them any good to have it in there. So we do want to prepare the clients for the possibility of extractions anytime we perform dental procedures. We don't want to be trying to call them while that patient is under anesthesia. Ideally, every dental estimate will have an allotment for extractions and express permission to perform them as the veterinarian sees fit. Because calling up the client and saying, hey, there's 10 teeth that need to come out, sometimes you'll get responses like, well, can we just take out 5? And those are not decisions that you want to make while the patient is under anesthesia. You want to have that conversation well in advance. And sometimes the veterinarian knows, that most of the teeth will need to be extracted based on that exam. Sometimes we're going to find things that we don't expect. So regardless of what you see from the outside, we should make preparations to do this by informing the clients ahead of time that it's a possibility. There are situations where the patient has such severe bone loss that to remove the teeth would compromise the integrity of the jaw. So the teeth roots are essentially providing some additional scaffolding or structure to that jaw, or in the process of removing them, there's so little bone that we would likely break the jaw. And this is usually going to be in patients with very bad dental disease. Those situations we may opt to leave the teeth in simply because the risk of taking them out kind of outweighs the benefit. So dental radiographs are going to help us a lot in determining whether it's safe and appropriate to remove teeth. We're going to do all the normal cleaning of our instruments, our dental instruments that we do with our other surgical instruments, but we also have to think about things like sharpening the instruments. If we have dull elevators for extraction or scalers, it's going to require us to use a lot more force to accomplish the same amount of work, and not only will we then be more fatigued and the procedure be less efficient, but oftentimes we're more likely to hurt the patient because we're applying a lot more force and getting a lot less done. And I've seen people take those winged elevators trying to do a closed extraction, so working it up and under the gum line around the tooth, and they're pushing so hard because it's so dull that they actually pop a hole right through into that nasopharynx, and that's not uncommon. It happens all the time. So we do want to make sure that they're sharp, and we should be sending them out for sharpening on a fairly regular basis for them, and what's not,